Thank you very much, panel members, ladies and gentlemen. My name is Mohamed Elmasry. I'm an ST8 trainee in Oxford. I'm also the group lead for HPV, and I'm the trainee representative for GBI HPVA. So, the UK HPV surgical training. So, if you can advise someone, let's say foundation, 2 years, core surgical training, another 2 years, higher surgical training, 6 years, 10 years, straightforward. But what is the reality? The reality is that you have so many things going on at the same time in order to get to the end of the HPV training. You have research, which can be anything between 2 to 5 years, depending what degree you're doing. Fellowships at the end of your training, which again varies. Maternity leaves, less than full-time training, out of program, for whatever you're doing, for a clinical or for personal reason. And through the Root Group, we have done a recent survey looking at all the specialities in the upper GI HPV, and the average is about 17 years from mid-school till you finish your training. Next, please. So, what is it about HPV surgery training? Well, it's complex surgery, and obviously I don't need to explain to the audience in the room here, but it involves lots of skills that you need to acquire. That starts from open surgery, laparoscopic, if you work in a transplant unit, and you're talking about organ transplant, multi-organ retrieval, lots of things to learn. And you can divide this into 2 periods. So the early to central period of training, which you're really focusing on the anatomical consideration, trying to come up with good techniques, dissection, tissue handling, and gaining confidence in general. And then you move into the later sort of phase of your training, and then you're trying to refine this technique, trying to anticipate what is the next step in operation, how to manage complication, how to prevent complication from happening, and how to gain autonomy. Saying all of that, when you look at the CCT requirement for HPV, actually you only need level 3, which means that you can perform the procedure under supervision. So that goes back to the complexity of the cases that we're dealing with. Next, please. But why robotic surgery training? And again, coming at this time of the day after we had all these presentations about robotic surgery, I don't think that there is much to add in this slide, but if you look back, the robotic technology has developed in the late 80s, but then over the last decade, there has been an exponential increase. And I found this paper, it was actually from 2018, talking about in the US, the use of robots in general surgery has increased by 10-fold. I'm sure if there is up-to-date data on this, will be much more than that. And just being part of the group, being part of the HPV community, you can see that lots of HPV units in the UK has adopted the robotic programs over the last few years. And for lots of reasons that we talked about, I'm not going to go through it again. But the results, the early results, are comparable to the laparoscopic surgery as minimally invasive from the safety point of view, from the efficiency point of view. But the general feeling is that robotic surgery is here to stay. So what are the skills that's needed? So it's pretty unique because the skills can be divided into technical skills and non-technical skills. You're talking about general knowledge of the operation, having some basic laparoscopic skills. You need to be able to gain access to the abdominal cavity, use pneumoperitoneum, the usual things that you learn in laparoscopic surgery or minimally invasive. But then you have a separate set for robotic surgery skills. But then robotic brings another challenge, which is the non-technical skills. What is the surgeon being, the operating surgeon being on the console, physically away from the patient? Not that much away, but not immediately by the bedside. You need different level, different skills of situation awareness, decision making, planning, when to convert, when not to convert, how to guide your assistant. All of these are different skills that you learn through your training, through the process. But also, you need team leader, leadership skills, teamwork skills, communication skills, trying to allocate your resources appropriately. Next, please. So, when you talk about basic robotic surgery training, there is 2 parts to this. So there is a patient side training and there is a console training. Patient side, we all know that, starts from positioning, establishing peritoneum, axis, port placement, which is specific to each procedure, the docking procedure, and then the actual assisting throughout the procedure. But then the console training as well, which we'll come to in a minute. You have simulation modules, whatever system that you're using, you have dry and wet lab, and you have supervised console operating or what we call POC training. But how is that translated to trainee? So trainees at the moment are sort of stuck in that patient-side training phase. And that's because of many things that, again, we talked about throughout the day. But in order to move from this step to the next step, which is the console training, or going to be the first operator supervised, that is still not fully there. So what is the current pathway for training? So we have clear pathway for surgical consultants. And again, being here at the end of the day, we had a presentation, how to set up the service, how to start your training, where to start, what level of experience or that you need or competencies that you need before you even embark on such thing. But you have clear things that you need to do, clear targets that you need to achieve, and then you are able to introduce this service or be able to conduct this service to the patients. But what is the training pathway for surgical trainees and fellows? And I know Jamed has been doing lots of work in that, the GBI has been doing lots of work in that. I've been going through research from urology, from America, from the UK, and it's all the same problem. There's a standardized training pathway for surgical trainees and fellows. I don't want to say it's not fully considered, but it's not there. You can't have a clear pathway that allows you to move from that column to the other column. So how does that impact the training? The way I see it, it's a double whammy. So you have the cases that, or what we call the easy cases that are being picked, that will be the trainee level case, that will be shifted towards robotic pathway to allow to proceed with the service. But also the laparoscopic cases that again used to be either fully or partly done by the trainees that have been taken away by the robotic surgery. So this is not a criticism to the system, but this is highlighting a problem, and this is not just me talking, this is talking to every single trainee that I talked with in the later stage of their training, and they are thinking the same way. So you can see, even in the press, and I think this is an article from the US, and where they've called it practicing in the shadow. Because it's all very exciting, it's all very great, and you can see the benefit, but it is, to some extent, is accompanied by a degree of frustration. So how can that be improved? So I think the first thing that we need is we need a clear training pathway for trainees, and that needs to be parallel to that of the units or the consultants. And that comes in with a change of the training culture. So when you talk about robotic surgery, you're talking about proc training, you're talking about simulation. But what about the good old training? Just simple training, mentoring. Because most of the consultants, pretty much all the consultants who will be undertaking part of this process will be experienced consultants who are happy to train, but they are limited somehow by certain constraints in the system that is stopping them from moving this forward to actually deconstruct the operations. If in colorectal surgery, when you go to the e-log book, and you're talking about doing a right hemicolectomy, and then divide it into 2 stages, we still don't have that in HPV surgery, which is different issue, and there have been recent research and publications about it. But all the HPV operations that we perform are a set of multiple steps, multiple small operations, if you wish. And then if you have a clear training pathway, or you have the ability to be able to train the trainees, I'm not saying that you will go in straight into doing one big operation, but even the simple handling, the starting the things, after you've done enough simulation training, after you've done courses, all the other things, why is that not part of the training? Why you are able to do half a Whipple's as an open surgery, but you can't even do a little part of the operation in robotic surgery? And this is what we need to do. We need a paradigm shift in how we're thinking about this. And we also need to move to competency-based assessment rather than numbers-based. And when you look at the curriculum for surgical training, which has changed recently, it's all competency-based. It's not important if you've done 100 laparotomy, because you might still not be good at it. Someone might have done 60 or 70, and they are competent doing so. So we need to move into that, to incorporate that within the training mindset. But then, the role of the industry, and I'm not sure how many of the industry partners do that, but the industry seems to be now focused mainly on driving service forward and driving the service with the consultant training. The trainee pathway stops at that first column we talked about before, which is, we're going to get you to be a good assistant. But then, this is going to be the consultant next day or next year. So why not incorporate that? Why not its parallel pathways here? And that needs to be facilitated. That needs to be incorporated. So in summary, the HPB training in the UK spans over 2 decades, which takes its toll on you. But robotic surgery will be, and is already, an integral part of the HPB workload in lots of the units, and I think that will become more and more as we go forward. The training shouldn't be overlooked when integrating robotic surgery into the practice. I think, personally, and from talking to other people, that needs to go in parallel. And that can be only achieved by having a clear, comprehensive training pathway which needs to be implemented. Thank you very much.